Hey guys, good evening. Let's enjoy the chest radiographs with Dr. Y. Today's session is 19 about missed lung cancer. Missed lung cancer. On left side chest radiograph, it is easy to find out the lung cancer. How about the right side image? It's not easy to find out the lung cancer. Let's review the session 18, usual features of lung cancer. Let's review. Number 1, lung cancer is usually diagnosed late in advanced stage. 2, avoidance and early detection of lung cancer are the best policy. 3, quit smoking is far better than conquering the lung cancer, the cancer. Before entering the session, I want to recommend this wonderful, nice, handsome review article about missed lung cancer, when, where, and why. Diagnosis, Intervention, Radiology, year 2017 by Dr. Emilia Del Cielo. Please read slowly and completely and repeatedly. I advise you to read this article. Let's enjoy the session 19, missed lung cancer. This is the first case. How do you feel about this image, chest radiograph? Yes, so easy, very easy. Why? Why this film is so easy to interpret? Let's contemplate about this. This is the second case with lung cancer. This patient also has lung cancer. How do you feel about this film, this image? I found nothing abnormal with this patient image. Maybe you too. I'll explain why about this film, this case later. There is nothing abnormal findings in this film. Let's contemplate. Let's compare these two films side by side. Left side is easy to find out, easy to diagnose as lung cancer, and right side is not easy to diagnose as lung cancer. What's the difference? Left side is in open field, open space, and right side lesion pathology is in ambush, hide in somewhere. So left side is easy to find out, but right side is easy to miss. Let's enjoy the articles previously which I have recommended to you. Factors leading to missed lung cancer on chest radiograph. A. Observer error, which means I made a mistake. B. Tumor characteristics. 3. Technical considerations. Let's go deeper. A. Observer error. It is most significant. A. Scanning error, about 30%, when nodule is not fixated on fovea. B. Recognition error, about 25%. It's observer's mindset. C. Decision-making error, 45%, most important. Observer's experience. D. Satisfaction of search. Loss of interest. B. Tumor characteristics. A. Tumor dimension or tumor size. This is the main factor. Bigger the better. B. Conspicuity. Contrast with background, sharper margin, density is important. That's why ground glass nodule is hard to detect. C. Location. Upper lobe lesion is hard to detect. Especially right side is harder to detect than left side. Anatomic noise is so much important. Overlying structures such as ribs, vessels, heart, mediastinum, and diaphragm. C. Technical considerations. A. Image quality. This is important. PA frontal and lateral view is much better than AP film, supine film. B. Patient positioning. C. Patient movement. D. This is the digital imaging period. So imaging is much better than the previous period, and even we can image process on our own monitor desk. On these several yellow round areas where we used to miss the lung cancer. In other words, lung cancer ambush themselves. This is apex. I told you before, be careful about the owl's eyes. Apex. Rib. Overlapped with rib. Right side retrocardia or paravertebral area. And below the diaphragm ridge, usually lower lobes. And on this one, first costochondral junction. Sometimes we call this area as student tumor. The most important area where accidents occur so many times, so many cancers are hidden here. Most important focus, hilum, retrocardiac area, and also lateral portion. Let's go to opposite side, open field, easy to find area. Where is it? The opposite of the missed lung cancer areas. Let's recall the history. The longest day of the invasion of Normandy. These areas are Omaha Beach of Allied soldiers. Omaha Beach of Normandy of Allied, mainly American soldiers. They are exposed to German soldiers in the concrete bunker. Who is easy to be detected? German soldiers or American soldiers? Yes, American soldiers in the open field. We are easy to detect lung cancers here in the open field. Have you ever heard the name student tumor? First, costochondral junction. With aging, and this costochondral junction becomes more prominent due to degenerative changes. It looks like a tumor, actually false tumor. Let's begin our cases. This is the real first case. Left side film, it looks normal. And 2 years later, what happened? You got it? Did you find? Hope to find out something. Look at the right apex. Okay, you got something. And got the difference between two films. Yes. And look at the left side film. Only 6 months passed more. What do we see? Yes. 4 centimeter large mass. Pleural thickening, pleural nodule, which means pleural metastasis, and pleural effusion, diaphragm elevation may be suggesting us phrenic nerve invasion. Yes, pleural metastasis. It means M1A staging. Only 6 months have passed. We will enjoy the missed lung cancer area from top to going down to the bottom, this way. How about this film? What do we see? We have seen this film before. Let's look at the first rib. I called it owl's eyes. How about that? Yes, right side owl eyes not clear, something like a cataract. Left side is okay. Yes, that's correct. This is superior sulcus tumor. How about this film? Sometime later, the result is like this. Enlarged tumor. Tumor has grown up, and the first and second rib have been invaded by the tumor. This is so notorious tumor named as superior sulcus tumor, squamous cell type. These two films have a 2 years difference, today and 2 years ago. You got something? Have you found out the difference? It's not possible. Not possible not only for you, but also for me. Here, look at this. This is normal. How about this? Something more slightly denser than before? Yes. Not so remarkable, not so identifiable. Today with CT, we found something. 1.5 centimeter cystic lung cancer of adenocarcinoma. This one. It's not easy, not possible, somewhat not possible. Usually we cannot find out the lesion like this. It's usual. You got the difference? 2 years difference. Please look at the student tumor. First cost-chondral junction. You got the difference? Yes, there is some difference. Slightly increased density, about 1 centimeter in the first rib or in the lung. We don't know, but this is the difference. This is axial CT of lung window setting. Oh my gosh, what do we find? 1 centimeter speculated nodule actually proven as adenocarcinoma. We found more in his lung. Yes, emphysema, severe emphysema. He used to be a heavy smoker. As I told you before, several times, many times, hilum, around the hilum is very, very important for detecting lung cancer. What do we see? Please point out the wrong point. What's wrong with this patient? Yes, right protracheal stripe is obliterated with bulging mass. Trachea is compressed to the left side. Even trachea is compressed to the left side. This is relatively large mass here. Right protracheal stripe obliteration usually means serious condition. On this axial contrast in NCT, we found conglomerated lymph node mass, actually small cell lung carcinoma here. That's why Right paratracheal stripe is obliterated and bulging mass are present. This one. Small cell lung cancer likes to live here. Their favorite sites. Let's enjoy another patient image. What is wrong with this patient? Please pay attention to highlight area. You may not. And also, I may not find something. Yes, normal, almost normal looking. Let's go further. How about this lateral film? It's evident here. Yes, we know that retrosternal triangle is black with nothing. Also, retrocardiac triangle is black with nothing. But we found something. That means this lateral radiograph was very helpful with this patient in this case. This is lung cancer. Let's go back. Maybe here. Increased opacity, a slightly irregular, ill-defined border of normal anatomy. But still I'm not sure about the findings here. With the lateral chest radiograph, we already know that the tumor is here. Yes, why this tumor was not visualized, not easy to be identified on the frontal radiograph was evident here. Yes, it was overlapped with hilar vascular structure on the frontal radiograph. We are all familiar with this patient, already have seen it many times. And actually this film is the highlight of this subject, this topic, session 19, missed lung cancer. This is the highlight, climax image. Yes, this is hilar tumor. Is it clear for you as tumor? Nothing abnormal like right side hilum? No, clearly it is abnormal because normal pulmonary vessels are not visualized and increased density, increased size, irregular border, and streaky density all around. Yes, this is the famous hilar tumor, hilar cancer of missed lung cancer. This is the highlight image of missed lung cancer. Please pay attention more. Oh my gosh, what happened to this patient at the same time with the chest radiograph was taken? This is tumor, and almost all of his body has metastasized small cell lung cancer cells and tumors, almost all of his body. We see only slight abnormality in the left side hilum, but its actual tumor burden is so much advanced, not imaginable. How far advanced? This is lung cancer, this is small cell lung cancer, this is hilar mass, somewhat missed lung cancer's shape. What's wrong with this patient? Yes, thorax is longer than usual. This means usually emphysematous lung. What else? Not yet? Okay, let's go further. 3 months have passed. What happened to this patient? Yes, infrahilum is increased in size and density with irregular border. Left heart border is okay, but aorta line is obliterated, probably 4 cm, about 4 cm mass in left lower lobe. Let's go back to 3 months before. Was it normal? I'm not sure, but this increased density in the infrahilar area, I suspect this one as lung cancer. Let's go down from hilum to below. We are familiar with this film, this patient too. He has underlying usual interstitial pneumonitis of honeycomb lung, and there is something increased density here, retrocardiac area, retrocardiac left lower lobe lung mass. Let's find out another tumor behind the heart. You got it? Yes, here it is. Her lung looks clean. She doesn't seem to be a smoker. Yes. She can have an operation here and prognosis seems to be good. How about this patient? Let's forget this right part tracheal bulging. Just forget it. What do we see? Yes, you got it. I got it. This one. His descending aorta is very tortuous, so this may interrupt or masquerade the tumor mass here. But this is tumor, not tortuous descending aorta. If we have missed something in the frontal radiograph before, in this case, lateral film will be helpful because tumor is here. Have you ever heard the name positive spine sign? It is simple. Retrocardiac area or spine area should be clean, black, with nothing, just nothing. But if it is white density, then it is something wrong. That is positive spine sign. This is tumor mass here. Yes, we can see on the axial enhanced CT the tumor mass here. This is tortuous descending aorta. Yes. Let's look at this film. What do we see? This is actually another case of not possible to identify the lesion on the chest radiograph case. Just normal looking film. On this axial CT, we found 1.5 centimeter speculated adenocarcinoma in right lower lobe, but it's just behind the right heart border, inside the right heart border, so that's not possible to identify for us with this chest radiograph. It's impossible to find out this lesion with this chest radiograph. How about your condition now? Very tired with these many confusing films, or getting more interested and funnier than before because the cases are so interesting? Please take a deep breath and take a rest for a couple of seconds, and let's go with this patient. Just enjoy the image. I think you have found something because you are already trained so much with missed lung cancer session. Yes, that's correct. You got it. Right heart, retrocardiac or precardiac, right heart area. Right side images 1 year ago, last year. What's the difference? We see the aorta line here. We don't see the aorta line here. And increased density, increased extent. So this is the mass. Relatively large mass developed for 1 year. Let's go down. What do we see? You got them? 1.5 centimeter nodule, you see? Is that in the liver or in the right lower lobe lung? Yes, in the lung. Although this nodule has ambushed below the diaphragm, we got him. We found him. Yes. We are trained now. We are experienced now. Most important factor of missed lung cancer is observers. Depends on the observer. Depends on the observer's experience. Yes, we got him. You see the nodule here, right lower lobe. Not in the liver, yes. Now let's talk about the conspicuity. These two films have a solitary single pulmonary nodule each. Let's find out these two nodules. You got them? Not yet? Sure, you got them. Okay. The teaching point of this slide is the nodule of B. Yes, this one. Everybody finds this one. How about this one? What's the difference? Yes, these three shows the conspicuity difference. Larger, easier. Sharper margin, easier. Denser density, easier to find out. Look at this. Smaller, ill-defined margin. Less dense. That's the reason why we sometimes don't find this kind of tumor here. Let's look at this film. Absolutely normal looking. Although we found nothing abnormal with the chest radiograph, we found a 2 centimeter ground glass nodule of adenocarcinoma in the CT. Regrettably, this kind of things sometimes happens with the chest radiograph. We can't help it. How about this film? I'm quite sure you'll get it. You'll get them. You have confidence and ability and capability to find out the lesion in this chest radiograph. Yes, that's correct. The owl's eye, right side. You got it. Yes, in the apex of a right upper lobe, there is a ground glass nodule proven as adenocarcinoma. This is the famous place where tuberculosis, acid-fast bacilli loves to live in. So sometimes we may be confused with the tuberculosis and adenocarcinoma of ground glass nodule. How about this one? Yes. First rib, second rib. In between, there is some increased density here. No increased density here. Okay? So this is wrong. Something wrong. Yes, we found ground glass nodule of adenocarcinoma in that area, right upper lobe. This is the last case. You worked very, very hard for now, and thank you for your efforts. What do you see? What do we see with this film? You got it? You got him? Maybe, maybe not. Yes, let's see the film later. What happened? 1.5 years later, what happened? Primary lung cancer increased, or hematogenous lung metastasis, right mediastinal lymph node enlargement, malignant pleural effusion, diaphragm elevation suggesting phrenic nerve invasion. 1.5 years later. This must have been the primary tumor at the time, I suppose. Thank you so much for your effort. From today, I'll give you 2 medical exam cases in every session in the latter part of the session. And regrettably, we'll quit the quiz session. Sorry for that. Let's start medical exam case number 1. What kind of pneumonia is this? Diagnosis, please. Medical exam case number 2. The patient has no sputum. The radiologic findings have not changed for 1 month. Diagnosis, please. Do you happen to know where have all the Marlboro men gone? Like, subscribe will be a big support to me. Thank you very much and have a good day.